and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Increasing HPV Vaccination Rates in Alabama. If you have any questions about anything being discussed today, please call or email during our broadcast. The number and the email address are on your screen now and will appear again later in the program. Also, the handouts are available online. You will need to register for this program in order to access those material. Hi, I'm Cindy Lessinger. I'm the Immunization Division Director for the Alabama Department of Public Health, and I'd like to introduce you to our famous presenters. First, we have Dr. Melinda Wharton. She is the Director for the Immunization Services Division at the Centers for Disease Control and Prevention. We have Dr. Jennifer Young-Pierce. She's the Cancer Control and Prevention Leader for the Mitchell Cancer Institute at the University of South Alabama. We have Dr. David Kimberlin, who is the co-director of the Division of Pediatric Infectious Diseases at the University of Alabama at Birmingham and the editor of the AAP Red Book. And last, we have Dr. Marissa Ladinsky. She is an associate professor for the Academic General Pediatrics at Children's of Alabama. I want to welcome everyone and wanted to thank all of our presenters for being here today. So let's get started. First, we'll start with Dr. Melinda Wharton to give us a little background about where we stand HPV-wise nationally as well as Alabama.
Thanks, Cindy. We have the HPV vaccine as part of our immunization schedule, and this is an opportunity to prevent cancers caused by human papillomavirus. It's routinely recommended for kids at age 11 to 12 and gives us an opportunity to prevent a variety of cancers that we'll be hearing about from Dr. Pierce a little later in the presentation. The vaccine was first recommended for girls in 2006, and along with at the same time, we had a couple of other vaccines recommended for routine use at 11 to 12. This graph shows the data from our National Immunization Survey, which is a large telephone survey that we use at the national level to track coverage for vaccines. The top two lines are two other vaccines that are recommended for routine use at age 11 to 12, the tetanus, diphtheria, acellular pertussis vaccine, and the meningococcal conjugate vaccine. And what you can see is at the beginning, coverage was low when the vaccines were newly recommended, but there were steady increases in coverage. And after a few years, we had high coverage, and they're now both above 80%. The third line down on the graph is coverage for HPV vaccine, at least one dose for girls. And early on, that curve diverged from the other two. We didn't have the same increases in coverage as we had for other vaccines recommended to be given at the same age. At the beginning of our program, we actually needed to give a 3-dose series. It's now been reduced to 2 doses if you start the series before age 15. But we did even more poorly with completion of the full 2-dose series, which is the heavy dashed line that's sort of in the middle. Later, we had a recommendation to extend HPV vaccination to boys, and that coverage has increased more rapidly and is diverging with coverage for girls, but it's still a little lower. But the bottom line is, in spite of the fact these vaccines have been part of our recommended schedule now for more than 10 years for girls, we still don't have the coverage that we need, and young people are being left vulnerable to cancers that otherwise could be prevented. Here's our data for the national level, and we now report coverage out at for both starting the series with 1 or more doses and for completing the series, which we call up to date, because kids may need 2 or 3 doses depending on where they started. And you can see that at the national level, although coverage is not quite where we want it to be, we have made substantial progress. And but with coverage remains higher for girls than it is for boys. But we have, again, we've made substantial progress. Coverage is not as high in Alabama as it is nationally. And you can see here our National Immunization Survey estimates for both girls and boys as well as combined together. Now, the National Immunization Survey is a large telephone survey that does provide these data at the state level, but in Alabama, we also are able to monitor coverage using the Alabama Immunization Registry imprint. And although the numbers may be small on this slide, we have listed here the coverage for HPV up to date as well as series initiation by county. And this is a real value in the state that clinic sites can actually now start generating a report to look at their coverage at the clinic level. So this is a tool that's now going to be available that providers can use. Imprint includes all doses that have been reported to the state registry, and so these numbers are somewhat lower than are reported in the National Immunization Survey, but that's the difference between vaccines that are entered into the registry and those that are provider verified but not in the registry. So this really is an important tool, and it allows us to monitor coverage at lower geographic levels. So why is HPV vaccine coverage so low? These next couple of slides are from a study done by Rebecca Perkins and colleagues in Boston. And by interviewing parents and providers, she and her team were able to identify a number of factors. This study was done a few years ago, but I think many of these factors still pertain. Parents reported they weren't offered vaccination, or it was presented as optional or not necessary. They didn't feel like their providers were really strongly recommending it, and they didn't feel like they had enough information. They didn't understand the reason to vaccinate at 11 to 12. Providers seem to be reluctant to give multiple shots. They might mention the vaccine but not recommend it strongly. They might make a judgment about whether or not they felt like the child was likely to be sexually active soon, and they had limited knowledge or experience with HPV and underestimated the risk of those outcomes. So providers did not really make a strong recommendation, but they did, and they delayed, which then led to non-vaccination. As part of our National Immunization Survey, we do ask why children have not been vaccinated. And one of the things we see is that often parents report that they actually did not get a recommendation for the vaccine. So we know that this continues to be an issue. Parents also stated that they didn't know about the vaccine. They felt that their child wasn't sexually active, so the vaccine wasn't needed, and that the vaccine wasn't recommended. Providers may underestimate parents' interest and in the vaccine, and some of them, and for some providers, HPV vaccine is not the priority that other recommended vaccines are. This is from a study by Melissa Gilkey and others, which did a survey of pediatricians and family physicians. And the green bars are the strength of the recommendation that the providers had themselves, that they were strongly supportive of Tdap and meningococcal conjugate vaccine, but were somewhat less supportive of HPV vaccine. The orange bars are their estimation of the parental support for those vaccines, and you can see that these providers in this survey felt that parents were not really very supportive of HPV vaccine at all. A similar study was done by Mary Healy and others in Houston, and once again, the orange bars are the provider's estimate of how parents would feel about different vaccines. And you can see that the providers thought that the parents would be supportive of most of the vaccines they were asked about, but less for influenza and much lower for HPV vaccine. In this survey, though, Dr. Healy and her team actually asked parents how they felt. And you can see that the parents' estimations were very high for all of the vaccines they were asked about. Why don't adolescents finish the series? As part of the study that Rebecca Perkins' team did, they asked parents and providers they asked parents of children who had started the series but not completed it why they didn't finish, and they asked providers why families didn't finish, or why their patients didn't finish the series. And what the parents said was they expected the clinic to remind them, and the providers said they expected the family to make an appointment. And so right there, that explains a lot about why we're having trouble completing the series. And with that, I will turn things over to Dr. Pierce. I'm going to skip through these.
All right, so I think what we just heard was that parents overwhelmingly state lack of knowledge. I would consider safety concerns, lack of risk, not understanding that it's recommended are all in the category of lack of knowledge. And as vaccinators, we really need to convey to parents the risk that their child has of acquiring HPV, and in particular of acquiring an HPV-related disease. Not all HPV results in cancer, because as cancer providers, we're doing a good job of detecting and treating precancer, but the burden of disease is very high. So first, we need to think about what types of disease. There are over 40 different HPV types. At least 14 of those are oncogenic or cause cancer. And when we think of the sites of infection, it can be any mucosal surface. So they're known to cause cervical cancer, anogenital cancers, oropharyngeal or cancers in the back of the throat, as well as changes in precancers related to vaginal, vulvar, and cervical cancer. This includes genital cancers in men, including penile cancers, and for both men and women, the anal cancers. So most men and women become infected with at least one HPV type in their lifetime. That means 80 million Americans are currently infected, and over 14 million new infections in the U.S. per year. That makes this more common than the common cold. HPV infection is most common in people in their teens and 20s, and most people, they never know that they have been infected because it clears on their own, asymptomatic. This latest update from the data in the CDC, I think, is really quite striking. The prevalence of any high-risk oral HPV was higher in men than women, and as high as 7%. But more striking is the prevalence of any genital HPV, which is 45% of all men aged 18 to 59, and 20% of all women aged 18 to 59 in the United States are currently infected with HPV. That's 1 in 5 to 1 in 4. That means it is very, very prevalent. And the prevalence of high-risk types was that number in particular, 1 in 4, 1 in 5 men currently infected with the high-risk types. Overall prevalence of infection up to 45%, or almost 1 in 2 of us. So a lot of people think cervical cancer is one of the good ones, that we do a great job of preventing cervical cancer, and cervical cancer is not a bad cancer to have if you have to have a cancer, etc. And it really is not true. First, I want you to know that in the world, there are 500,000 cases of cervical cancer, and over 250,000 of those women die. 50% of women die from cervical cancer in countries that do not have regular screening programs. For us in the United States, there's over 12,000 cases and at least 4,000 deaths in the United States. That means 1/3 of the women who are diagnosed with cervical cancer in the United States will die of their disease. It is an astronomical problem, and it's something that we can do better. This graph also shows that unfortunately our survival has tailed off. We've done the best that we can do, but because these cancers present late and there are limited options for treatment, the survival remains in the 60 to 70% range despite advances in cancer treatment. So we think of the quarter of cervical cancers occur in very young women, where also the treatment impacts their fertility, and for most will take their fertility away. So this is the tip of the iceberg. The cancers are actually the tip of the iceberg. The real problem is the number of cases of precancers. 1.4 million cases of low-grade cervical dysplasia. 1 in 10 women will have an abnormal pap in their lifetime, and of those, 330,000 new cases of cervical dysplasia that is a precancer. That's more women diagnosed with cervical precancer than breast cancer every single year. Now we can commend our OBGYNs for doing an excellent job of treating this and for finding it in a precancerous stage. But if we had a vaccine to prevent breast cancer, we would be out there vaccinating like crazy. And here we are with a cancer and a precancer that's more common than breast cancer. We need to do a better job. So this is the graph showing the vaccine preventable illnesses. Each of those bubbles is a vaccine preventable illness before vaccines were available, and now that we have vaccines available. I will tell you these numbers are in the hundreds to thousands of cases. If we tried to put a slide that showed 80 million cases of HPV, the bubble would not fit in this room. But if we try and compare this to cervical cancer, let's do that. So this is deaths from cervical cancer in the world at 145,000 then, prior to routine screening in the United States. And then this is cervical cancer and pre-invasive disease of over 350,000 cases per year. It takes up more than any other vaccine preventable illness. And here we are now with our low vaccination rates, as we've heard. We're still doing a terrible job. So the cervical cancer disease that I've relayed to you is, again, the tip of the iceberg. There are multiple HPV-related cancers. We know that screening alone in cervical cancer is not going to get us to the vaccine rate, to the prevention rates that we want. So screening shows a low rate of total prevention. Vaccination only is a better rate of prevention, but screening and vaccination together really combine to create a very powerful tool for cancer risk reduction. So here we are, 26 million girls under 13 in the United States currently. 168,000 of them will develop cervical cancer in their lifetime if they're not vaccinated, and 54,000 of them will die from cervical cancer if they are not vaccinated. It is a big, big problem. So cervical cancer, again, is but one of many HPV types, and we know that the rates between men and women are equaling out. The rates of, unfortunately, oropharyngeal cancer in men, white men ages 50 to 60 are at particular risk for oropharyngeal cancers, and those rates of cancer are still on the rise. There is no screening test. They're often diagnosed at stage 2 or higher and treated with life-altering radiation and surgery. So this is the rates for Alabama. This is very interesting data. This is the first time that we are seeing a rate of oropharyngeal HPV-related cancer in men that is higher than the number of cervical cancer cases in women. So this is the trend that we saw nationally. We are actually already seeing here in Alabama with higher rates of HPV cancers in men than women. So this is why we vaccinate boys and girls. So again, just showing that point that the number of cancers in men and women is nearly equal in the United States, and as we've seen, almost higher in Alabama. So we're vaccinating boys and girls to protect girls from HPV-related cancers and to protect boys from HPV-related cancers. This shows the vaccine coverage of the types of HPV that cause those cancers. The blue bars are the types of HPV that are covered by the vaccine. The light blue bar is the HPV types that are not included in the current nanovalent vaccine, and the white are the types of cancer that are caused by other things. So we have 2 patient videos I want to set up for you. The first is a patient with oropharyngeal cancer who talked briefly about his experience, and the second is a woman diagnosed with cervical cancer here in Alabama.
I had a swollen lymph node and in my left neck, and having had strep throat numerous times, I knew that this meant something, but I felt great. I was diagnosed with squamous cell carcinoma back in 2012, summer of 2012, and the pathology report indicated HPV-16. I was aware of the HPV virus. I didn't know that much about it, and I knew that it related to cervical cancer in females, but didn't know the association with head and neck cancer. I don't understand any hesitation with having children vaccinated for HPV. We're on the cusp now, and we could annihilate this disease or make it something like as typical as a smallpox vaccine or any of the other vaccines that we've done so well with. I'm in great health today. I'm in great shape. I feel great. It has been a journey, an unfortunate one I would not want anyone to have to go through. Woman, man, it's just a very unkind disease.
I was diagnosed with cervical cancer. I was told in my early 20s that I was at high risk for HPV. I was supposed to go to the doctor every 6 months for checkups, and unfortunately I did not do that here the last several years, which has been a little overwhelming with some things that had been going on in my life. I had skipped out on going to see my OBGYN for about 4 years. I had a regular routine pap smear done, and they told me that I would need to get a biopsy, but I even delayed that. Delayed that for almost a year, and when I finally went to go back to my OBGYN, they did what is called a leap, and unfortunately they did the biopsy and then the leap, which reflected that I did have cervical cancer. As a nurse, yes, I did know some about HPV, but I will tell you that even being a nurse, you have that thought process in your mind that the information I knew was that it was slow growing, and you assume, which is a dangerous thing to do, that it's not going to be me, and you hear other people say that, and you think, well, how did they think? How did they think that? Why would you take any risks with that? And life gets very busy, and I think in particular for women with children and working and doing things, we kind of put ourselves last. And even though I knew I was at high risk, I was lacking health insurance at the time, and put it off. So I knew the risks. I mean, I was aware of them. I can't sit here and say that I wasn't, but I didn't take the proper steps, which was getting proper screenings. I was not in the time period or young enough where the HPV vaccination was available to me, and had dealt with this for a long time. Every time they had gone to do a biopsy before, it had always come back negative. And so you assume. I have 2 teenage daughters. I have a 13-year-old and I have a 15-year-old. Both Ella and Davern have been vaccinated. All vaccinations, everything we do within the medical profession has some sort of, risk. There's a risk involved. But do the benefits outweigh the risk? And for me personally, when it came to my children and how bad this scared them, for mom to have to sit down and say, I have cancer, even from the day that I was diagnosed, I had to wait almost 2 weeks to know how bad this cancer was. It was a bad 2 weeks. I mean, you're contemplating life, and I was lucky in that it was just a hysterectomy. But again, I can tell you from reaching out to other women and what they've had to go through, you want your children to be vaccinated. The benefits of the HPV vaccination are going to outweigh the risks. And so both my children have been vaccinated. I think my biggest concerns going forward is, I think one of the hardest questions that I had to ask Dr. Scalisi was, in an appointment, I realized that I still have HPV. I think I thought for just a moment, they took out my cervix, they took out my uterus, they took all those things out. And yes, that is where HPV, from what I understand, that's the host that it most likes. but that puts you still at risk for a lot of other cancers. I'd like to sit and tell you that once you've been diagnosed with cancer and they give you that green light, you're okay. You know, that fear goes away. But I can tell you honestly that I live with that fear still sitting here with you today. Any little thing that comes up, I still think, do I have cancer? You know, is this, oh gosh, this is bothering me today. Fatigue was probably one of the biggest things looking back that probably I noticed. I look back thinking, working 12-hour shifts as a nurse, that I was struggling. I mean, really struggling, and I don't now. And so now anytime something small like that comes up, you know, or that I probably don't need to be too concerned about, it seems to play out in my mind in ways that I wish that it wouldn't. HPV vaccination, again, I go benefits outweigh the risks. We do that with all vaccinations for children. Again, we take a risk in anything that we do within medicine, whether it's a blood pressure medicine, whatever it may be. The HPV vaccination is going to give your child the benefit of being protected and perhaps avoiding everything that we've just discussed today, that fear that I still live with today, and having to go through treatments that affect you the rest of your life. Unfortunately, most people at some point in time in their life have HPV. This is not uncommon. The stigma has to be taken off that somehow this is uncommon. It's not uncommon. This is very, very common. Most people, I think it's 80% of the population at some point in time is going to have HPV. The question is, which strands do you have? Do you want to leave your child unprotected? Do the benefits outweigh the risk? And I encourage every parent to look up every bit of information that you can and speak with your doctor about the benefits and the risks and how this can best help your child to prevent these things from happening, whether it's now or in the future. I encourage every parent to get their child vaccinated. It is important, and I hope that their child never has to sit like we are today, that I'm doing, and that they can protect their children from those risks. It's important.
So, those videos are so powerful. I think I'll really just go on to say, as our patients describe to you, the treatments can be very impactful on their life. And unfortunately, some still live with a risk of both recurrent disease as well as other cancers related to HPV in the future. There is a significant economic cost to HPV-related disease in our country, which we know is impactful to our healthcare system. And I'll turn it over to Dr. Kimberlin.
I'm not sure how you follow something like that. This is just my personal opinion. I think those videos ought to be looped in every waiting room of every doctor's office in the country. We'll give you data, we'll give you information, we'll give you perspectives. I'll talk about the AAP's recommendations for HPV vaccination, but the reason we're sitting here talking about it is because of the people's lives that it touches, and those videos demonstrate to me the human aspect of this, and it's something that we need to be always aware of as we are as physicians. We need to do a better job of finding ways to prevent people from dying of vaccine-preventable diseases. Well, I appreciate the opportunity to be here today. I'm going to talk about the American Academy of Pediatrics recommendations when it comes to HPV vaccination. I think it's important to start with disclosures. I do a lot of antiviral studies. They're multi-institutional studies funded by the NIH. Almost all of my research funding comes from the National Institutes of Health. I do a couple of industry-sponsored studies every now and then. Right now, over the last 12 to 24 months, I've worked with Alios and Novavax. These are on RSV treatment and vaccine studies, respectively. All monies go directly to the University of Alabama at Birmingham. They do not come to me. This is a rather squinched up copy of the Red Book. It won't be square. I think this is the way it was projected when the graphics or the optics were changed on the screen. But it will be coming out. The 2018 edition will be coming out by the end of this month. For all AAP members, the print edition of the Red Book now will be available. This will take us back to where we were back in 2006 and before that. So you do have to go onto the AAP website and do a couple of clicks like you would with Amazon or something along those lines, and then it will be shipped free of charge if you're an AAP member to your designated address. And the recommendations that I'm going to be going over are reflected in the 2018 HPV chapter. So I think it's important to think about where we are now in relation to where we have been. As of October 2016, FDA has approved a 2-dose series for the nanovalent HPV vaccine, the Gardasil 9 product, for patients who are 9 through 14 years of age. I'm going to show you some of the data on how 2 doses can be viewed to be as good as 3 doses. Through 2014, almost all HPV vaccine used in the United States was the previous Gardasil product, the Gardasil 4 or HPV 4 product. There also was an HPV 2 called Cervarix. It never really caught steam in terms of the market share here in the United States. It did in Australia and other places, but not in the United States. By 2016, almost all of the HPV vaccine that was used was the nanovalent vaccine, and as at the current time, neither the HPV 2 nor the HPV 4 vaccines are currently available in the United States. So why did we feel comfortable making this recommendation of going with a 2-dose series versus a 3-dose series of the HPV vaccine? Well, the data that we have showed geometric mean titers from the 4-component vaccine. This would be 6, 11, 16, and 18, the far left column on your slide in front of you, showing antibody titers to those 4 strains. And of course, the HPV 9 vaccine contains these 4 strains plus 5 additional. And what you see in the middle 2 columns are girls, that is, people under 15 years of age, who are receiving 2 doses of the vaccine, either dose 1 at 0 months and then dose 2 just before 6 months, or dose 1 at 0 months and dose 2 just after 6 months. The numbers in the cells of the table correspond with the titers of anti-HPV 6 or anti-HPV 16. And then the far right column shows women receiving a 3-dose schedule. And these numbers are, clearly you just look at them and you can tell the numbers for younger people, even younger people getting 2 doses of the vaccine, are higher, quite a bit higher than they are for women getting 3 doses of the vaccine. This is not terribly surprising. We've known from even pre-licensure studies that children 9, 10 years of age are going to have a higher antibody response than do older women or older men. So it's not terribly surprising to see this, but it is very encouraging to see it with respect to 2 doses, and it allows us to consider how we would use 2 doses with respect to recommendations. Well, what are those recommendations? What you have on this slide is the beginning of those recommendations, and it states that for persons who are initiating vaccination before their 15th birthday, they are recommended to receive now a 2-dose HPV schedule. And look at the intervals here. 0 months, that's the dose number 1, and 6 to 12 months. So the recommendations allow for annual visits for these young children, young teenagers, without having to bring them back at a 6-month interval that you might not be bringing them back anyway. So it gives you some flexibility to better work immunization and completion of immunization scheduling into your standard follow-up within your practice. For people who are on or after their 15th birthday at the time the vaccine is initiated, the 3-dose recommendation stands. That's at 0 months, 1 to 2 months, and 6 months. We don't have data to change that recommendation at this particular time. Additional information is reflected on this and the following slide. Persons who initiate vaccination with any of the products before their 15th birthday and received either 2 doses or 3 doses at the recommended intervals are considered adequately vaccinated. In other words, you don't have to think of a catch-up kind of program or anything along those lines. Persons who are initiating vaccination with any of the 3 products at any point on or after their 15th birthday, though, do need 3 doses to consider adequately vaccinated as individuals. Additionally, HPV-9 may be used to continue or complete the series that had previously been started with either Cervarix, the HPV-2 vaccine, or the Gardasil 4 product. For persons who have been adequately vaccinated with either HPV-2 or this should say HPV-4, my apologies, there are no recommendations at this time for additional vaccination for additional catch-up with HPV-9. And if the vaccine schedule is interrupted, you do not need to restart it. In terms of immunocompromised people, females and males 9 through 26 years of age should receive 3 doses of the vaccine if they're immunocompromised. And those persons who should receive 3 doses would include primary and secondary immunocompromising conditions and HIV. Malignant neoplasm also would be a list for immunocompromised patients, autoimmune disease, immunosuppressive therapy. And the recommendations for 3-dose vaccinations does not apply for children under 15 years of age who have asplenia, for instance, or asthma or chronic granulomatous disease. You can see these on your slide, CNS anatomic barrier defects like a cribriform plate defect, complement deficiencies, diabetes, sickle cell. These are not immunocompromised in the sense that they would need 3 doses in terms of full immunization. Instead, they can be considered fully immunized if started before 15 years of age and they get 2 doses. So let's talk now. Let's shift away from why 2 doses are okay as compared with 3 doses for children under 15 years of age. And now let's talk about a difference in emphasis that you're going to see in the 2018 Red Book from the Academy. Slightly different emphasis than perhaps you're going to see from CDC, but not inconsistent. There's not daylight between these two. We are seeking from the Academy standpoint simply to provide more flexibility in the approach, and specifically it's the approach at age at initiation of vaccination. The data that support this are going to be illustrated on this slide and the next couple of slides. They emanate from Minnesota, Olmsted County, Minnesota, where they are able to track demographic information and deliveries and number of visits and addresses of people and so forth. So they've got a really good tracking system there, and they looked at data from 2006 through 2012. And what you can see represented on this particular table is the likelihood of a patient completing 3 doses of the HPV vaccine by the time they're 13 and a half years of age. That's the second row. Just below that is the likelihood of them completing 3 doses of vaccine by 15 years of age. That's the row just below. Second row from the bottom, the likelihood of completing 2 doses of vaccine by 13 and a half years of age. And then bottom row, 2 doses completion within 15 years. And you can see that the second column from the left shows if they start vaccination at 9 to 10 years of age. The column immediately to its right is if they start vaccination for HPV at 11 or 12 years of age. And there is a statistically significantly improved likelihood of completing vaccination either with 3 doses or with 2 doses within the time frame specified if they start vaccination at the 9 to 10 year age range as compared with the 11 or 12 year age range. And if we look at this with logistic regression analysis on this slide and the following slide, these are in the far right columns, adjusted odds ratios whereby we adjusted or they adjusted for gender, race, insurance status, and year of first vaccination. You can see that highlighted in this yellowish font is an illustration that somewhere between 13 and 14-fold increased likelihood of completing the vaccination series if this is a 3-dose series we're talking about, if they start vaccination within the 9 or 10-year age range as compared to the 11 or 12-year age range. Same data looking at 2-dose vaccination. The numbers are smaller, the confidence intervals are wider, but it looks like there's about a 22-fold increased likelihood of completion of vaccination series if that is started within the first earlier period of the range from 9 through 14. So in other words, 9 to 10 as compared with 11 to 12. So what does this lead us to in the Red Book? Well, the Academy now is saying that routine HPV vaccination for males and females should be occurring. That is not a new statement, and ACIP, CDC are very much in step with that. The AAP recommends starting the series between 9 and 12 years at an age that the provider deems optimal for acceptance and completion of the vaccination series. This gives more flexibility, more backup to pediatricians and family practitioners, people who are administering vaccines, to be able to use it at 9 and 10 years of age to begin with, as compared with 11 and 12 years. But it still allows for 11 and 12, again, if that fits your practice better. The ACIP recommends starting the series at 11 or 12 years and states that vaccination can be administered starting at age 9 years. That's where there's a difference in emphasis, but not daylight between the two organizations. When HPV vaccine is begun at 9 or 10 years, other adolescent vaccines, the MenACWY, the Tdap vaccines, still are recommended to be administered at 11 or 12 years of age. Providers are encouraged. Now, this is standard language. This follows the conversation we've just heard from the prior two speakers about this being a cancer vaccine, but I include it not to say there's a difference between the 2015 and the 2018 red book, but rather to drive home the importance of what is on this slide. Providers are encouraged to recommend use of HPV vaccine as they would any other routine vaccination in adolescence or in childhood. Research demonstrates that parents are most influenced by a strong recommendation by you, the provider, the pediatrician, the family practitioner. You are the one who understands the needs of that child best, and your personal testimonials as to why it matters, why you believe it, why it is important that they get their child vaccinated, that is what's going to have the biggest likelihood of impact. You sit in the driver's seat here, and we certainly hope that you take that car into drive and move it forward, because we need to do better, as has been illustrated. Opportunities to prevent cancers and deaths are being missed. And that's simply a situation that we need to improve upon. So with that, I thank you very much for your time, and I'm happy to turn it over to Dr. Ludinsky.
Thank you very much for the opportunity to be here. And as a frontline pediatrician and a longitudinal continuity provider, one who trains the residents, it's my pleasure to kind of bring together the voices of those you've heard dealing with HPV-related illnesses in adulthood to the front lines of our youth and our teens and the prevention that we all can give. Nothing. And as you've heard from Dr. Pierce, this is not just prevalent. The magnitude of this prevalence is basically astronomical. Many of us may be sitting here harboring HPV and not knowing it. So let's turn our attention to our youth. Those of us in Alabama have to deal with a statistic it's not easy to be proud of, but regardless of where your state falls, our youth are active. Our youth can be very active. The need for this prevention does include an appreciation of the transmission, but as we'll talk about later, it doesn't need to be the key point in the message. In Alabama, and still in some states, the code for public schools is an abstinence-only curricula. Know that with the information teens get in school or lack of it can vary. And don't ask doesn't work to don't tell. The Youth Risk Behavior Survey is an excellent piece of research done every 2 years and tells us what our youth really are doing. For us in Alabama, the prevalence of our STIs along with what our youth are engaging in puts us at a very high-risk place. Our college students in the state of Alabama share that risk. So yes, we have to appreciate transmission, but we will talk about our messaging. Intimate contact, not straight up, can also transmit it. All right, so let's look at prevention and what we can do as pediatricians. If there was a vaccine to prevent your child from cancer, wouldn't you embrace it? That was the messaging that we've all seen over the past few years, and embracing it is critical. And if we haven't, understanding why and what those barriers are. The first vaccine was licensed about 10 years ago, 2006, just the 2-valent. That was expanded rapidly along with the licensure for boys in getting 16, 18 with cancer or cancer possibility, along with venereal warts, and then expanded to what most all of us are giving in our offices, the 9-valent today. How safe is this? Very. The biggest side effects are what teenagers simply can do with vaccines. Syncope, and they wake right up. Oh yeah, and arm soreness. That's about it, and it's been very well studied, okay? Does this vaccine work? David has told us. We've heard a lot of data around efficacy. But here's a very glaring example of how quickly it works. Australia is a world leader, one of a few countries that has incredible coverage of HPV, thank you in part to school-based clinics and administration for catch-up and giving it. When they first began giving the vaccine, as we did, to females only, they saw a super sharp drop-off in new cases of venereal warts. But the graph on with the males who were not being vaccinated at that time, look at the massive drop-off there. So this vaccine works, and it works to prevent, and it works fast. It has completely changed the screening tests that are done in the United States. So this has been embraced. Pap smears are now routinely not done every year, and they're started later. How can we frame the conversation to really emphasize it and drive it home with families? We've seen this graph, and it shows us clearly that pediatricians and primary care providers underestimate the emphasis that parents may put on the vaccine. Okay? And we've seen this too. While we are increasing beautifully in our coverage of the other adolescent vaccines, Tdap and Menactra, we're still behind in HPV. But nothing is more expensive than a missed opportunity. Never miss a missed opportunity. This is the message I give my residents every day. Okay, she's here for suture removal, but is behind on 2 vaccines. They're being given. Vaccine checks every time. And this is an easy way that we can implement this in our clinics. Okay, first, a message, a strong message. Sophia's here for her track physical at 11 to 12. She's due for 3 vaccines today, and there is a way for phrasing it, very objectively, and we will give those shots at the end of the visit. We are also great and ready to engage in discussion, but we start with an objective presentation. Okay, why does my child need this? Immunization before exposure, because this prevents cancer, and it works way better when given to an 11 or 12-year-old versus an adult. So we have the opportunity to protect your child from cancer. But wait a minute. I've read about this. Immunization before exposure. It has been very well done in prospective studies, both that giving youth information about HPV and its protection does not send them a signal to go on out and do it. That is not how the pre-adolescent and adolescent mind works. And this is often very comforting to parents and to caregivers and to us as pediatricians to hear. Okay? I've heard it has bad side effects. I mean, so-and-so said, and I saw all over the internet. Sore arm, and sore arm. That is the data. That's what we see. Okay, if you get to the 3rd screen on the internet, you will see the use of freedom of information by a group that is made up of medical professionals. The ACP is not the American Academy. That is a small group of very conservative physicians who are exercising their opinion on certain matters. This vaccine does not cause sterility, yet HPV infection clearly can. The American Academy of Pediatrics, who underscores the standards of care with which we practice, has the data and will clearly relate it, okay? It's giving the strong recommendation from physicians, families' inherent trust in us, that really can change the outcome. Would I give it to my own child? Absolutely. And this one statement can open hearts and minds for so many. Those are my 3 youngest of 5, along with my son's wife, my daughter-in-law. They have all been fully immunized. My son in the middle was not too pleased, but it was not optional, and he was fine. We, in our clinic and around the state of Alabama, have been engaged in a simple QI initiative to change the culture, and by there changing the rate of vaccine acceptance. We simply, in a resident teaching clinic with 97 providers, changed a culture in never missing a missed opportunity to start and to continue the HPV vaccine at 11 and 12-year-old visits, along with labeling charts by our nurse of who could be eligible. And we were able to very quickly turn that around. Our youth, when they finished their series, were given a very nice certificate on thick paper. And don't you know, this was the one piece of paper we never found on an exam room floor. Incentivizing is great. And there it is. You providers are the key. And with that, thank you for the opportunity to be here and address you.
Thank you, doctors, very much for that information. And I think bringing you four together to present it from all directions is invaluable. So we are going to see if there are any questions. I'll first turn to anyone here in the audience if you have a question.
Good morning. My name is Beth, and I'm a public health employee here, and I have a question regarding oropharyngeal cancer risk. So males are at an increased risk for oropharyngeal cancer. What provider would be best for doing the oropharyngeal screenings? We have OBGYNs that do cervical screenings, and we have primary care physicians that are doing others, but the oropharyngeal, like you said, is kind of by the wayside.
First, I want to state that there is not currently a screening test for oropharyngeal cancers. These are cancers that occur at the base of the tongue or in the crypts of the tonsil. So it's not something your dentist can see. It's not something that's even visible to the naked eye at the time that it is a stage 1 cancer. We do have research tests for HPV, oral HPV in both men and women. And I am sure there's ongoing research nationally to develop a screening test, but currently it does not exist. I think we could ask the question going forward, who would be the best person to do that? Probably a dentist, given that that's the person that you see most commonly for your oropharyngeal health. And it's something that men and women both see those providers on a regular basis. So I think that we recognize dentists are partners in this fight, both to increase HPV vaccination as well as to encourage our large adult unvaccinated population to continue with routine screening behaviors for the HPV vaccine, but we're not there yet.
Nor are we there in a licensed widespread use of a screening test similar to what we can do in her office for males. So as all of these great people work incredibly hard to develop that, let's protect our boys and men.
So I'm looking to the audience to see if they have any questions either by email or by phone. I'll also look to the audience if there's any other questions here. So I did have just a quick question. I think you mentioned it, Dr. Lindinsky, on one of the slides, that if a provider had to give the one statement to a parent, because I think providers are concerned about the time it takes if a parent starts asking questions. I do know some providers that are using their staff to kind of mow the way for them a little bit, so make sure everybody has buy-in at the provider practice, and then the doctor would come in and say, what would be the one best sentence?
We have the opportunity to protect your child from viruses that can lead to the development of cancer. We would like to protect him or her, them today.
So, of course, moving away from that sex message to always cancer prevention is going to be very important, and that we need to start educating our parents more about that, because many of them are still stuck on the sex message, and we can't seem to get away from that.
And we should also not be afraid to discuss directly that, yes, the virus can be spread by intimate contact. Intimate contact not only is normal, but it is something we expect our youth to engage in as they grow. I didn't say sex, I said intimacy, intimate contact. That's kissing. That's being near you can't, but being very factual, very mature, very adult, and very immunization before prevention. Before exposure.
Right, yes. Dr. Pierce, do you mind sharing, you shared with us yesterday about a recent case?
Sure. I was seeing patients here in Alabama and saw a young woman refer to me. She was 16 years old, and she had a VIN2. That is a precancer of the vulva. There's 3 grades of precancer, 1, 2, and 3, and 2 was clearly on the way to becoming a cancer. So this was a young woman. We actually pulled her immunization record from Imprint, and she'd received 1 HPV vaccine on time at age 11. Unfortunately, she saw her pediatrician several times over the next few years for her flu shots on time every year, and never again was vaccinated for HPV. She said she didn't realize that she needed another one, and she was never recommended to have a second injection. And unfortunately, here I am seeing her for HPV-related VIN2. This is something that can be treated with things like acid, lasers, and surgery to the outside skin of her genitalia. And these are the kinds of things that without protection, our youth are left open to experiencing, even at a very, very young age. It's something any parent would want to avoid their child going through.
And Dr. Lieutenant, did someone have a question? Okay, you had mentioned about, I think, the one for a doctor to say, I would give my child this vaccine, is truly the personal touch the parents are looking for, not just from a professional standpoint as your physician, but we're both parents here, and I wouldn't miss this opportunity for my children.
I have been asked that by countless parents over time. Well, did you give it to your daughter? Yes, and my sons. Absolutely.
I might be the only person on the panel who is vaccinated. So I was just starting.
You youngin'.
Well,
she just saying she a youngin'.
Outside the age range when it came out, but I was just starting my fellowship in gynecologic oncology, and I recognized the importance of protection. I probably was the only person who was still single at 30 also, but I convinced my physician that it was important for me to be protected, and while outside of the recommended age range, that I felt I was still at risk. And so I can say to patients and parents, not only do I plan to vaccinate both of my daughters, but I have been vaccinated myself.
That's an excellent testimony. Right now we don't have any questions coming in, and we are closing in at the end of the hour. I do want to thank all of you guys for coming. I think this was a very special hour, and this program will be on demand, so we want to make sure that anybody who was unable to make it during a 10 to 11 on a Friday, that this program will be made available to them, and we will do extra promoting of this program. So I want to thank the audience for being here as well, and we really appreciate it. Any last words from anyone? Nope. Thank you.
Thank you.
All right.